I'll record this. Okay, you're going to start by identifying your patient, get a TPR for that morning, and then always look in the chart to see if there's any big changes with previous TPRs or previous weights. Yes, JC, when I'm done recording, I'll convert it and send you guys the link so you'll have this video. The other thing that you're going to do, I know sometimes the scales are set in pounds. So if you have the weight in pounds, you need to convert it to kilograms, which is dividing by 2.2. Your kilograms should always be less than your pounds. And that's kind of a way to double check to make sure you went the right direction. And then some things you want to have, your stethoscope. You're going to want to have a watch so that you can count the heart rate and respiration. The pulse oximeter will be in the room, so that should be in the room. Make sure it's there. Having something to write with, and maybe a calculator, you know, because you have to calculate the heart rate, respiratory rate. You need to start getting good about multiplying by 4 in your head. So you're going to want to do that. And then you're going to have a sedation sheet. So it's not like a full anesthetic record. It's just going to be where you're going to record your values. You're going to have calculations, and I believe you do those the day before. And Mrs. Long will check your calculations. Once they are checked, I believe she draws up the medications. I did put, go ahead and draw up your...
She does draw them up.
Okay, so they are going to be checked, and she may combine them, because what we do is we mix them in one syringe. You're going to give the dexdomitor and the torb in one syringe, and you guys usually will give that IV. And so let me go over the medications, and because I haven't gotten into drugs with you guys. So there's just some brief on this handout. I wrote the drug, and I wrote some brief things that you guys should look for. So atropine is going to be calculated for every patient, and this is an anticholinergic. It is not automatically given to each patient. The reason we use a drug called atropine is either to prevent or treat bradycardia is the primary reason. The other reason is it dries up salivary secretions. So if they have a lot of saliva, but one of the other side effects is this does slow down the GI tract. Now, giving it one time, I'm not too worried about GI activity, and you're not using it in species that are dependent on their GI tract. You know, like when you use it in horses and cows and guinea pigs, there are some implications to atropine. But for the most part, the reason you guys are giving it is because the drugs will cause some bradycardia. So you need to check with Mrs. Long whether you're going to give it. When I give atropine, the primary thing that I look for is sometimes the heart rate can go too fast. Usually in these guys, you guys are going to be giving low dose atropine. But for the future, anytime you use atropine in a protocol, whether in a pre-med or after the fact, you can get the heart rate to go too high. So I have watch for tachycardia. And the other thing is to make sure you guys have some eye ointment in there, usually like those artificial tears, because it can also cause some dry eye, and we don't want to cause any ulcers, okay? The main sedative you're giving is dexdomitor, which is, the generic name is dexmedetomidine, but dexdomitor is an alpha-2 agonist. That's the drug family. We can give it IV or IM. You guys will be giving it IV. If you cannot hit a vein, sometimes she will give it in the muscle, and then it'll take a little bit for it to kick in. But when you give it IV, it's going to, you know, probably within about a couple minutes, they're going to become sedated, and they will continue to become sedated. So I don't like give it, and then in 2 minutes, I'm trying to take an x-ray right away. You know, sometimes you're going to see them varying levels of sedation when you use it. The big thing to watch with this drug is bradycardia. There's a reason it's capitalized. This is a normal effect of the drug because when you give it, it causes a peripheral vasoconstriction. So all of their peripheral vessels narrow, and all of the blood that was peripheral gets sent to the core. And so technically, if you took these guys' blood pressure, their blood pressure would be very, very high. And what the heart does to, combat that is the heart slows down. And I'm talking heart rates, anywhere from 35 to 50 beats a minute. 30 would be extremely low, but I've seen heart rates range. And so when I tell students, and I will hammer this about this drug, if you have a dog under sedation or anesthesia and they have a heart rate of 40 or 50, you better have given an alpha 2. If you've given this drug, that's appropriate. If you've not used this drug and you get that heart rate, then there was either vagal stimulation or your dog is extremely deep. So just keep that in the back of your mind, that they will be bradycardic, and that is normal, and you just want to watch that as the anesthetist. Now, the mucous membranes, you're going to be checking the color. They will look pale because they're vasoconstricted. So they may go from bright pink to pale pink, and your CRT is normally less than 2 seconds. It can be up to 2 seconds because of the vasoconstriction. So you can see extended CRTs. I don't like anything over 2 seconds. Like you're getting 3-4 seconds, that's a problem. But it can be longer than it was for their TPR, and they are going to look pale, and that is a normal effect of the drug. Okay. The bradycardia, and this is important. If I get a heart rate of, there's times in between x-rays where the dog is just laying there unstimulated. And then you guys start moving them to take the x-rays and the heart rate comes up a little bit. So I always kind of test the bradycardia by like rubbing them, pinching their toes, moving their legs. Does stimulation give me a little boost in heart rate? And that is good. That's a good sign. If I have a dog that's 40 beats a minute with stimulation, without stimulation, like they're not moving, I'm a little more concerned that they're maybe a little deeper. That you can still do the x-rays, you're just going to have to watch them closer. So I'm going to tell you that sometimes the bradycardia can improve. They'll do like dips. So like when you're moving them, the heart rate goes up. And then when you stop moving them, the heart rate goes down and then it goes up. So sometimes you're going to see that, and that's a normal effect of this drug. I have a note here about the respiratory depression that you see with dexdomitor. They are sedated, they are going to be breathing less. My kind of cutoff is 6 breaths a minute. Now that's pretty low, but I've seen dogs get that low. But if they go below, if they're at 6 breaths, I'm going to watch their color, make sure they're not cyanotic, make sure they're not having a hard time breathing. But they can be that low. So you just want to watch the respiratory rate. So you're going to get a heart rate, and so that's what this drug does. This drug lasts about 30 to 45 minutes. It really depends on the patient. I've seen people get 45 minutes to an hour, and I've seen these dogs start wiggling after 30 minutes, and that is just patient dependent. So as a guideline, this drug will give you, and you should be able to get your radiographs done. You should be able to get your radiographs done in that time frame. Okay, so you should be okay. And the nice thing about this drug is it is reversible. There is a drug called antecedent, and the good way to remember that, it makes them anti-sedate. Antecedent, anti-sedate. So if you get into trouble, if Mrs. Long or Dr. Ritz or if whoever's looking at the dog, if they are concerned, you can give a reversal agent IV and they'll wake up pretty quickly. But we try to not reverse them if we don't have to, but that's a nice thing about this drug. Okay. The third drug you're going to use more than likely is butorphanol. And butorphanol is an opioid agonist antagonist. And yeah, I think I just had a delivery, Brittany, on my porch. So yeah, he's a big guard dog. So butorphanol is primarily used for pain management. The reason we're using it, these dogs aren't having anything painful done. It enhances the sedation of dexdomitor. So you're using it to enhance sedation. Butorphanol does have sedative properties, but it's primarily an analgesic. The big side effect with butorphanol is respiratory depression. And again, I've already told you where my cutoff is for respiration. So you follow the same guidelines. You will potentially see bradycardia with butorphanol, but it's usually not severe. The bradycardia in this protocol is coming from dexdomitor. It's not coming from butorphanol, okay? It is not reversible. So if you give butorphanol, you're stuck with the effects. Now, opioids, some people may be aware, certain opioids are reversible with Narcan, but that's the pure agonists like morphine, fentanyl, hydromorphone. Those are reversible, but butorphanol is only partially reversible, and the effects of reversal are kind of mixed reviews. I've never reversed butorphanol in all the years I've been in practice. Never done it, okay? It is a controlled substance, so Mrs. Long will have to get this, but it's a Schedule 4, if you remember from pharmacology. That's not a super high schedule, not a lot of abuse potential. Nobody's having a good time on butorphanol. And if they try that, they're just really idiotic. So I will say that. Now, monitoring, some guidelines for your heart rate. Now, for the canine, dogs are very difficult to say, this is the normal heart rate in a dog. You look it up, you're going to get anywhere from 60 to 160. I've seen 180 reported as a range. What I do and what you guys should do is you're going to have a morning TPR and a morning heart rate on that dog. Say it's 140. You do your TPR. If the heart rate drops 50% of their morning heart rate, I'm getting concerned. So for a dog that has a heart rate of 140, half of that, or 50%, is 70. So 70 is like okay, do we want to give atropine? Do we want to, again, if they get to 70 and I stimulate them and they go up to 82 and they go to 68 and they go to 74, they're staying in the low end of their heart rate, but that'll be up to Mrs. Long or the doctors if they want to give atropine. But I have a note here. If you get a heart rate of 60, everyone used to say, don't let the heart rate go below 60. But that's a great heart rate if you're a Great Dane, but not if you're a Chihuahua. Okay, so I've preached this many times. The bigger the dog, the lower their normal heart rate. And to give you an idea, when Bo is sleeping, I've taken his heart rate when he's laying next to me. He's about 48 beats to 52 beats a minute with no drugs. That's just him sleeping. So I think you guys should practice with your animals at home. Practice taking their heart rate, feeling their pulses. Some places that you can get a heart rate by listening. You can get a heart rate by putting your hand on the chest. You get a pulse rate by feeling the femoral artery, the dorsal pedal artery. They have a carpal artery. So if you can't get your stethoscope in there and listen to the heart, there's other places where you can confirm a pulse rate. But remember, a heart rate is done by feeling the heart, listening to the heart. A pulse rate is done by feeling an artery. So there is a difference between a heart rate and a pulse rate. Both are going to confirm your animal has cardiovascular function. Okay. I went into radiology once, 2 terms ago. Everyone was standing around and they were like concerned about the heart rate, and they called me in and they're standing there. And I'm like, well, I'm like, what's the heart rate of this dog? And they're all like, and I was like, get a heart rate. And they're kind of like, and I'm like, put your hand on the dog's chest and feel its heart. Like they're kind of fumbling with calculators and what do I do? I'm like, put your hand on his chest. Feel the heart beating. In an emergency, if you can't get your stethoscope, where can you confirm your animal is alive? Okay? Put your hand over their chest around the 4th to 7th rib space. Put your hand on their femoral artery. Put your fingers on their dorsal pedal, which is below the hock, medial on above the paw. So in between the paw and the hock, that long part of their paw, you put it on the inside. You put your fingers there. You can feel what's called a dorsal pedal. Pedal means back foot. okay? So somewhere confirm, and you guys should be doing this every 5 minutes. More often if you're concerned, but every 5 minutes you guys are gonna have to be recording the vitals. Now, if it's a cat, you guys may be using cats. Cat heart rates are kind of universal. A cat heart rate should always really be above 100 beats a minute. It's extremely rare for a cat to come in to your clinic with a heart rate below 100. Like if it's an awake cat, I really don't like anything below 140. I did have a super chill Maine Coon cat that used to come into oncology, and his heart rate was 120. We checked blood pressure, everything, he was normal. So that was low, but we discovered that that was normal for that cat. But normally you're gonna be in an awake cat, you're usually in the 160s, 180s, 200. I'm getting to that, Brittany, coming up. So for the heart rate, 100 is kind of my cutoff. Anything below 80 really needs to be watched closely. So with dexdomitor, you can have heart rates or heart rates in cats that get to 80, but you're going to want to watch close. You're probably going to end up giving atropine. But I have a note here: when using dexdomitor with gentle stimulation, you should be able to bring up the heart rate. If you don't, you check with Mrs. Long or you check with the doctors and say, do we want to treat this with atropine? Respiratory rates for the dog and cat, I have a goal. Now, these are anesthetized guidelines, okay? These guidelines are under anesthesia. I want to say in an awake dog and cat, it could be like 24 to 36. But what I want you to know, and Brittany, this is why I'm talking right now, I'm only focusing on anesthetized heart rates or respiratory rates. They can be 8 to 24 breaths a minute. A cat is usually going to have more. A dog is going to usually be a little bit less. But again, your cutoff is they should at least be breathing 6 to 8 breaths a minute minimum. If they're getting below that, they may be too deep. They may need to be reversed. Then you look at all the other vitals. I've already told you mucous membrane and CRT, pink in less than 2, but these guys will be pale, and your CRT may be close to 2 seconds due to the vasoconstriction with the drug. But what I will tell you, as the drug wears off, when you get closer to like the 30-minute mark, their color will, because the vasoconstriction starts to wear off. So usually the heart rate starts to come up a little bit, the color gets better, they should start to be breathing more. So around that 30-minute mark, you should see an improvement in respiratory rate, heart rate, color, things like that. Now, you guys will be using an SpO2 probe. That's what goes on the tongue. The reason you're using an SpO2, and I always want to make sure students know, why am I using this monitor? What does it tell me? The pulse oximeter is assessing oxygenation of the animal, okay? What is the oxygen saturation of the hemoglobin? Now, sometimes because they're vasoconstricted, this probe can sometimes have an issue. You may not be able to use a pulse oximeter, and that may be because it's not working great. But they were getting into something. What you're going to want to look for is anything above 95% is normal. If you're getting between 95 and 90, it's considered lower. We don't like anything below 90. So 90 is my absolute cutoff. But the problem is you have to verify that that's a correct reading. Sometimes that sits on the tongue and it blanches out their tongue for an extended period of time. What I usually do if I get a bad reading, I take it off, I rub the tongue, I moisten the tongue with some water, and I put the probe, sometimes I wipe the probe off with alcohol, because a lot of people put them on these tongues and they get like a film, they don't clean them, and that impedes the light. There's a red light and it should shine from underneath the tongue. So the thing is, you have to verify, is that correct? So normally what I do is I'll move the probe into a couple different spots, and then I will go back and check and see if I move my probe 2 or 3 times and I keep getting 92, 92, 92, it's probably 92. If I move it, a lot of times you move it and it improves the reading. So I don't panic when I first get a pulse ox reading that's low. You want to verify. And another little tip, I've sometimes taken the probe and put it on my finger. If I'm standing here breathing, talking, I should be above 95, 96, 97. So if I put it on my finger and it reads 92, unless I'm laying on the floor, not breathing well, I'm probably not 92, and maybe it's a probe and it's not the patient. So there's a little bit of troubleshooting. And again, when we do the monitoring lecture, I'm going to go more in depth about that. But for now, I want you guys to know you're going to be using that. Yes, that's my point, Lauren. If I put it on my finger and I was truly like in the 92s, I might feel woozy, I might feel lightheaded, I might look a little off. I mean, if a person is that low, normally they might be having a hard time breathing and they would show some impairment. So that's my point. If I put it on me and I'm standing here talking and I feel normal, it's probably not an accurate, because machines malfunction. So I just gave you some guidelines here as far as, as far as what is kind of expected. Are there any questions so far about the vitals as far as mucous membrane, heart rate, respiration, things like that? Now let me move on to reflexes, because whenever I get crappy readings or I'm concerned, you're sedating them, you're depressing the central nervous system, which is depressing reflexes. So the other thing that you have to look at is the overall condition. So muscle tone and reflexes are also monitored. We don't record this, but this is something that we monitor. Palpebral reflex, if you remember from anatomy, this is where you tap and you look for a blink. Now these patients are sedated. They're not going to have, they shouldn't have a super like brisk blink. They could have a little bit of a blink because they are not anesthetized. They are supposed to be somewhat conscious, but palpebral can be diminished. Their jaw tone, if you try to open their mouth, they should resist you a little bit.
Did you get moo?
Huh? I don't know if someone's talking to me. So you want to have, the other thing is that sometimes people try to pull the tongue out. This animal should not let you extend their tongue out of their mouth completely. They should try to pull it back. Now they might not be as strong, but they should give you a little bit of resistance. Their eye position can be central, or they're looking at the bridge of their nose. That's called ventromedial. And if you did shine a light in their eye, the pupillary light reflex is where they constrict the pupil. If you're super concerned, you can assess that they should have a pupillary light reflex. It's diminished. If you look at my notes here, all of these reflexes are diminished, but they are not going to be completely gone. But guys, this is going to vary, because when we give this drug, when we give these drugs, I have some that it hits them like a ton of bricks, and I have some that are a little more awake. So when you give it, we don't a lot of times know what to expect. So that's why all of this is guidelines. But I'm going to tell you, I gave this combo to a dog once for radiographs on emergency, and the dog had a heart rate of 32 to 28, which was super low. His eyes were central. I completely could open his mouth and pull out his tongue. I could have put a tube in his trachea, which is, this should not do that. This drug is sedative. It is not an anesthetic. This dog had a super profound reaction. So we ended up reversing him and waking him up, because I was looking at all these parameters and I'm like, this dog is way too deep on these drugs. So this is why I'm giving you these guidelines of what a patient should and should not do on these drugs. Now, I want to tell you, number 7 here is important because during the procedure, we're going to have varying levels of sedation. When you first give it, they're going to look a little awake, and sometimes you start working with them and then they get really sleepy. So they tend to twitch on these drugs. Sometimes they're laying there and you'll see them like they'll twitch and it freaks people out. That will sometimes happen. They can be responsive to loud sound. So what I've told you is everybody in that room should be quiet. The beeping, the moving of the machines, opening doors, dropping stuff on the floor. If you're the anesthetist or you're by that table, someone should always have a hand on your patient, especially by their neck, because if a dog bites you sedated, they tend to not let go because they're not all here. So I've seen people bit by sedated animals. I've seen people get cracked upside the head by sedated animals because they were over the patient and the patient woke up. So you always have to be aware of what's going on in the room and be aware that your patient has an ability to react, not what you expected. So always have a hand on them. Always be quiet. And then what I think normally you're going to do is monitor every 5 minutes. But I want you to realize when you get to the 30, 45-minute mark from the time you gave the drug, a lot of these animals are going to be coming out of sedation. So they are going to start to maybe twitch more, lift their head, move. And so, at that point, you're either going to be done or you're maybe going to have to give the dog more drugs. A lot, like I said, when they did AJ was at about 45, 50 minutes. And when I went in the room, he was wiggling. It was enough to get their last x-ray. Like he didn't need another dose because they were just almost done. So normally one dose should be enough for you guys to get all your x-rays accomplished. But if you're the anesthetist, I want you to realize when you get to that 30-minute mark, some patients are going to start to wake up and you need to watch them. And hopefully you start to see your respiratory rate go up and your heart rate going up. And you should see an improvement in vitals, okay? And color and pulse quality. Now on recovery, at the end of radiographs, you're going to decide, do you want to give the reversal agent? Some of these animals, like I'm trying to remember even if they reversed AJ. I'm thinking he was pretty awake. Sometimes you guys will give half the reversal. You won't use the full amount. Sometimes you'll only give them half. And sometimes if the dog is moving, they'll just say, we're not going to give the reversal agent because they're awake. So what you're going to want to do is you put them in the recovery cage. You want to get a post-op TPR probably while they're on the table. These guys will also get cold because they're vasoconstricted, and the radiology table, they can't really be on a towel. So they're laying on a cold table, air conditioning. These guys' temperature will drop. I didn't go over normal temp, but normal is 99.5 to 102.5. I've seen these guys, especially cats, get down into the 95s. Hopefully we don't get down to the 93s. So they may need to do towels, bear huggers. Yeah. So that's all that I want. That's basically it. I'm going to, I know you got to go in. Let me just show you one thing. I need to scan this, but I hand wrote out all of the drug. I did a 50-pound dog, and I wrote down the doses and how I calculated it. I'm going to scan this, okay? And then I'm going to give you a math sheet with some calculations for you to practice. So I will go through the math and continue the PowerPoint tomorrow. I just have to get this scanned here, and then I will send you this whole document electronically. So I worked through a 50-pound dog. I worked through all the drugs. Now I don't do that little box math. I just write it out like this. But if you follow this, you should be able to do your math. Again, this is just an example of how I do it. You'll get this with the packet that I just went over, and then I will send you guys some practice problems. I may make that due next week just to practice some math. I'm going to send you guys an email and explain everything because I'm going to make some adjustments to our schedule, but I know you guys got to go, especially going into radiology. So I'm going to record this, or it's recorded. I'll convert it, email it to you with the handout, and then we'll just meet tomorrow at the normal time. Any questions? Okay, if there's no questions, I'll go ahead and end this and be looking out for this recording and the handout to come this afternoon.